Mostly respectful professor and dear colleague, I'm Amin Amirat, PhD student in genetics. I will go for oncogenes in breast cancer and possible treatment options with my colleague, Surgeon Dr. Mikhail. First of all, our agenda is as you see. I will talk about the first 5 points, and my colleague will continue the remaining part. So at first, we talk about introduction. So breast cancer is a heterogeneous disease which required update on scientific research to offer patients the best possible and personalized treatment. Modern surgical treatment of breast cancer is recently been reviewed, and it's clearly a field of continuous change and improvement. The change in treatment strategy is a challenge given that prognosis is already acceptable. The collaboration between specialties across different countries and different knowledge background is needed to exchange experience and improve international guidelines. That's why surgeon and genetic specialists work together for this article. After that, we'll talk about epidemiology. So, breast cancer is the first cancer to affect women in most countries of the world, followed by lung cancer and colorectal cancer. The statistics showed that the incidence of breast cancer is higher in developed countries like USA, Europe, and Australia than the less developed countries like African and Asian countries. However, the mortality rate is much higher in underdeveloped countries due to the lack of diagnosis and treatment means. Breast cancer can be divided into two types. Sporadic breast cancer, which is the most common breast cancer resulting from accumulation of occurred and uncorrected mutation in somatic cell genes. And hereditary breast cancer, which result from the loss of heterozygosity at the level of tumor suppressor genes, such as BRCA1 and 2 in classic hereditary breast cancer or P53 in Li-Fraumeni syndrome. The alteration of genes is due to the action of risk factors that are subdivided into two categories: non-genetic factors such as aging, late menopause and pregnancy, hormonotherapy, as well as the modern lifestyle, including smoking, alcohol usage, and fast food. The genetics factors are due to the Mendelian transmission of cancer predisposition genes such as BRCA1 and 2 and P53. Breast cancer is caused by the alteration of different types of genes. The main genes are the proto-oncogenes, which after transformation become oncogenes and confer the cancerous phenotype. These oncogenes encode for the growth factor EGF, growth factor receptor like ERBB2, or transcription factors such as MYC gene. Tumor suppressor genes like BRCA1 and 2, which are the most implicated in hereditary breast cancer, P53, which is always mutated in all cancer and can be associated to hereditary breast cancer in the case of Li-Fraumeni syndrome. We found also that RB protein is involved in hereditary breast cancer because it regulates BRCA1 and 2. The steroid receptors such as ER alpha are also involved. In addition, several other genes are involved in breast cancer as apoptosis genes, invasion and cell adhesion genes, and angiogenesis genes, but with a lower penetrance. Now I let Dr. Mikhail continue the rest.
Thanks a million, Dr. Amin. Because we are all working in the behalf of the human being and the behalf of our patient, so we must go secondly to know what are the clinical features of breast cancer. We must remind that the breast cancer develop clinical symptoms rather late at advanced tumor stages. So typical signs may include changes in breast size and or shape, symmetry or asymmetry, palpable mass, typical or atypical, skin changes, whatever they are, redness, edema, and pitting of the hair follicles, nipple changes, inversion of nipple changes, or blood changed discharge, axillary lymphadenopathy, and also in advanced stages, ulceration. Here you can see how we can manage in the patient the palpable mass, how it looks like, also enlarged axillary lymph nodes and skin retraction, either nipple retraction or nipple discharge, pseudorange, inflammation, or carcinoma in Courvoisier. All the times we are looking for diagnostic scheme or algorithm in order to manage our patients without forgetting the triple assessment for this patient, but we must take in account the age of the patient, as my colleague mentioned before. So if the patient age was lower than 30 years old, we must go for clinical assessment, probability of the malignancy. If low, so re-examine within 3 to 10 days, and after that reassure and follow up. And if it's high suspicious mass, so we must go for ultrasound and fine needle aspiration. What we must see there, if we will see cystic lesion, so just with clear fluid to assure and follow up. And if we will find residual mass with blood fluid, take core needle biopsy. And if we will take this core needle biopsy, it might be benign or malignant, and I'll talk after that about it. And if it will be solid lesion, suspicious mass, so we must go for core needle biopsy. And likely penile mass, we must treat as needed and observe. If there's gross, so we must go for core needle biopsy. And sometimes, if difficult to reach the lesion, we must excise it. And if the patient is higher than 30 years old, we must firstly do scanning with mammography. And all the world now are going for the scanning program with mammography to all the women above 30 years old. If there is suspicious of mass, we must go for core needle biopsy, and if difficult to reach, excise it. If it's benign, follow up. If it's malignant, just imaging with MRI and do lab diagnostic with receptor testing tumor markers, and also staging with lymph node biopsy. Possible treatment options, not just surgery. Possible treatment options can be also radio and chemotherapy, and also other targeted therapy. We mustn't forget the role of multidisciplinary team. So the surgeon, the oncologist, the pathologist, and all other colleagues which are going with us to choose the needed choice for every special patient. In early stages of the disease, we can say breast conserving therapy. So lumpectomy followed by radiation therapy. If in intraoperative lymph node is seen, so we must do evaluation by sentinel lymph node biopsy and also axillary dissection. Also the adjuvant systemic therapy, hormones, and targeted biologic therapy in all of this. Here you can see the breast conserving therapy, and also locally advanced disease, we can go for some choices of non-adjuvant systemic therapy and followed adjuvant therapy. And if advanced metastatic disease, systemic treatment followed by palliative surgery. If gestational breast cancer, remember that it's not the type of surgery, stop it, but you can go for anything after the second or third trimester. If non-invasive carcinoma, you can see it in this slide, either ductal carcinoma in situ or lobular carcinoma, you will go for breast conserving therapy or lifelong surveillance and chemo radiation. I was very happy to be with you with my colleague. Thanks a million. If there are any questions remaining to genetics or remaining to surgery, we will be very happy to answer it. If not right now, we will be very happy to answer it via mail. Thanks.
Thank you.